Esophagram, AP or PA. Patient can be prone, supine, or erect. If supine, place right arm up to hold barium. Image receptor is 2 inches above shoulders and the mid-sagittal plane. The central ray is perpendicular to 1 inch inferior to the sternal angle, or T5, or 3 inches inferior to the jugular notch. Expose on expiration after last bolus swallow. Upper GI or stomach, posterior, anterior, or PA, 10 by 12 image receptor. Patient prone with arms up beside the head. The central ray for stentic body habitus is the level of L1, or 2 inches above the lower lateral rib margin and 1 inch left of the vertebral column. For the astentic body habitus, the central ray is 2 inches below L1, or 4 inches below the lateral rib margin. For the hyperstentic body habitus, the central ray is 2 inches above the level of 1, or 4 inches above the lateral rib margin and near midline. Expose on expiration. An alternative is an AP axial. For the hyperstentic body habitus, a tube angle of 35 to 45 cephalic will allow better visualization of the greater and lesser curvatures and duodenal bulb. For infants, a 20 to 25 cephalic tube angle is recommended to open up the body and pylorus of the stomach. To demonstrate a hiatal hernia or fill the fundus of an astentic patient, the patient may be placed in Trendelenburg position. Use shoulder braces. The PA or AP stomach best demonstrates a barium-filled stomach and duodenal bulb. The upright projection shows the size, shape, and relative position of the filled stomach. In the prone, the stomach moves superiorly and spreads horizontally. The pyloric canal and duodenal bulb are well demonstrated in patients with an astentic or hypostenic habitus. Upper GI right lateral. Place the patient in a right lateral position with arms up by the patient's head and knees flexed for support. For the stentic body habitus, the central ray is at the level of L1 or duodenal bulb, or the lower lateral margin of the ribs, and 1.5 inches anterior to the mid-coronal plane, midway between the anterior border of the vertebra and anterior abdomen. For the aesthetic body habitus, the central ray is 2 inches below L1. Place the bottom of the cassette at the iliac crest. For the hyperstentic body habitus, the central ray is 2 inches above L1. Expose on expiration. The lateral projection of the stomach shows the anterior and posterior aspects of the stomach, the pyloric canal, and duodenal bulb, especially with patient of hyperstentic habitus. Upper GI or stomach, right anterior oblique, 40 to 70 degrees. From a prone position, place the right arm down and the left arm flexed at the elbow up by the patient's head. Flex left knee for support. Rotate the body 40 to 70 degrees to place the right anterior body against the table. More rotation for hyperstentic body habitus and less for astentic body habitus. The astentic body habitus, the central ray is 2 inches below the level of L1 at a 40-degree oblique. For the stentic body habitus, the central ray is at the level of L1 or 2 inches below the lateral rib margin and a 45 to 55-degree oblique. For the hyperstentic body habitus, the central ray is 2 inches above the level of L1 and near midline at a 70-degree oblique. The RAO view demonstrates the stomach's pyloric canal and the duodenal bulb in patients with stentic-type habitus. Peristalsis is more active with a patient in an RAO. Small bowel series, PA. Patient is prone unless unable. Place patient's arms up beside the head. Use support under the ankles. The central ray for the first timed image is 15 to 30 minutes after drinking and is centered 2 inches above iliac crest or high enough to include the stomach. Watch the fluoro. Subsequent images at 30-minute intervals or as per protocol The central ray is at the iliac crest, exposed on expiration. The study ends when barium reaches the terminal ileum. The entire small intestine will be on each image, the stomach on the initial images. Time marker and completed examination when barium reaches the cecum.